All right.
Oh, hey, Chris.
Hey Chuck, how are you?
I'm good. I'm kicking back at home.
Yeah, why are you at home
Yeah, it's the middle of the day. It's what is today? I don't
on a
even
Wednesday?
know.
So Wednesday, it's usually your two-room OR day. So a little staycation action. What's going on there?
Oh, that pains me that you had to bring that up. I'm in the throes of recovery. I had my uni knee replacement 8 days ago, and let's just say it's more than a carpal tunnel.
Ah, okay. Partial knee replacement, so a young man's surgery, so to say. Good for you. But yes, well, it's more than a carpal tunnel. I mean, this is probably a gross overestimate, but when patients ask me how much things are going to hurt, I kind of use drilling in bone as a as a as a threshold for how much pain they're going to be in, and you certainly had some bone work done.
Yeah, I haven't mu taken much in the way of narcotics. I took tramadol. It is super interesting. The whole process was interesting. It was the computer navigated, blah blah blah. Outpatient. I was home by 12:30. All that was fantastic. Um, the block lasts 48 hours, and so you feel like, wow, this is nothing. But they did warn me that the block would wear off, as we all know in upper extremity surgery, and it was tough when the block wore off. I took tramadol and hated the feeling. I took like two pills, and then I took a couple of oxys at night, and then just been taking Tylenol and anti-inflammatory. And interestingly, I've been taking pregabalin. They do that for 2 weeks twice a day. And I don't have any nerve symptoms, thank God. And I guess this is preventative.
Great way to stay ahead of it, I guess. Multimodal pain management, as they say.
As
Single
they
shot
say.
block, long acting, all the different types of medications. So I'm glad you're feeling up for at least recording a podcast. I know you've been on some meetings. Super interesting. We're all waiting to hear if you're gonna say something crazy because you're hopped up on something.
Well, I was a little worried. Tatalia was yelling at me not to email. But this is the last day because tomorrow I have B school. And then I go back on Monday, and my light reentry half day is now up to 39 patients. And I'm like,
Mm.
that is not a half day. My God.
Yeah, that's so. Just out of curiosity, did you just kind of let that happen by saying yes to things, or just kind of, your nurse kind of knew that you wouldn't say no, or?
I think it was one of those creep things where it started too high and then you had to add a few people on. My mistake was I should have said I will see 20 patients or whatever the number was to try to have a light day, and I didn't do that. I just said half day. So
Ah, yes. He didn't put the appropriate guardrails around it.
yeah, we I do so I usually, I don't know about you, I usually see a patient, I dictate, the residents and fellows don't dictate. And I usually do it almost after every patient or maybe after every 3 or 4 patients because I like to stay ahead, stay on time and get my dictations done. I don't think that can happen on Monday with me hobbling around. But I did mention the faculty meeting this morning that this new AI generated note option is super interesting, and there's probably listeners who are ahead of us on this. But essentially, the one we're trying now, you use your phone, it sort of records the conversation, turns your conversation, and you have to be a little, funny about how you talk to share what you're doing when you do stuff. But it does a great HPI. Physical exam is plus minus, and the assessment plan is plus minus. But if I just do that for every patient, then at the end of the day, I'll remember the patients and can populate the note.
Do you see this as a replacement to the human scribe?
100%. It is definitely not there yet, but it is 100% a replacement. And it's fast. Like from the time that you leave the room and then I go back to the main computer in the hallway, it's done. The note's there.
That's impressive. I mean, I'm still striving. I like to leave myself room to grow and improve, so I'm still striving for Chuck Goldfarb levels of efficiency. I do ask our residents and fellows to start the notes for the patients that they see. And I still, I end my clinic a little bit earlier in terms of patient slots because I know how long it takes me to dictate and be out of there by the time that I want to be out of there. So perhaps as I, turn the corner and become wiser in my practice, I will eventually do all the notes by myself, but I'm not there yet.
Well, I would just ask if there are any listeners who have this down or been using AI, we would love to hear from you.
Right, and I know there are a lot of people that have experience with scribes. I was talking with our hand travel club. You know, they're basically convinced me that I need a scribe, and I've actually been had it on my to-do list to talk to you about getting a scribe. So we'll see. Supposedly the numbers that they were talking about, it pays for itself after a certain number of patients. So obviously AI could be an even more cost efficient solution once it gets there.
Yeah, I think scribes do quickly pay for themselves if you add on two patients a day or something like that. The problem, of course, is that scribes are, come and go, and you spend a lot of time training someone, and then they go, and it's, develop relationships. It's hard.
Yep, absolutely. All the better if your scribe is Siri or whatever whatever artificial
That's right.
intelligence thing we're using today.
That's
Bard.
exactly right.
So
So,
we have a couple of things to go through today, right?
yeah,
We've got a fantastic HBR article that I think is pretty relevant. We don't need to go into the details of the article, but really talk about the broad strokes. And we've got a few cases, but first we probably should thank our friends over at Practice Link.
absolutely. The Upper Hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
Becoming a physician is hard. It's really hard to get into medical school. Finding the right job doesn't have to be. Join Practice Link for free today at www.practicelink.com/theupperhand.
So, I sent an email around to our hand crew and said, for those of you who perform in-office needle aponeurotomy, which, most of us do it, and we do it in office because that's the point. I shared that one insurance company has, in their infinite wisdom, not been paying, so we're not going to do it anymore. How stunned are you by that?
I guess, well, I'm never stunned by what insurance companies do because it's in their best interest to maximize profits and minimize inpatient care, to be honest with you. But is the needle aponeurotomy or a similar procedure something that typically would require a prior authorization? Because it makes little sense to do if you're trying to take care of the patient in an expeditious manner. I just don't know what something analogous that might require a prior auth for an in-office procedure.
So when I started doing these back when you were in grade school in 2008, I think it was, we did try to get immediate prior auth in the office. And then slowly and but surely, all the insurance companies said you don't need prior authorization. So this is just a flat no. You cannot do this procedure in the office, which is just stunning to me.
Well, I mean, because if you think about it, the easier thing for them to do is to say no, so that you don't do it, or that you do it and they don't have to pay for it. But if you think about the ramifications of them saying you can't do this in the office, you're then doing it in the operating room with or without an anesthetist involved, which is crazy because it's so much more expensive. It makes absolutely no sense from a long-term perspective. But again, if they're looking for the easy wins, then yeah. But I mean, it's not like there isn't an evidence base for this procedure. It's clearly evidence based. It's clearly cost effective for certain dupuytrens contractures relative to something like a collagenase injection.
Yeah, it's exactly right. I spoke to the medical director for our region. He was great, said all the right things, and nothing's happened. So we're not going to do it anymore. I feel for the patients.
Yeah, that's tough. I mean, honestly, I had to every time that I want to come out and do a needle, I used to not even think about kind of, what insurance they have, et cetera. And I'm still not absolutely sure where to check in Epic for the insurance thing. I think I know, but when it's not there, I'm like, I'm stuck. If it's not on like the first part of the screen that I look at, I'm like, I don't know. I asked the nurse to just help me. But I don't think about that stuff. And sadly now, the realities of American healthcare, you have to think about it, which stinks because, you don't it's hard because you don't want to go into a room as you taught me when I was your trainee. The Goldfarb rule is to go into the room once. So if you have to go in and out of a room, it's
You
more
lose.
energy, more time, so if you I don't like having to go in a room checking insurance beforehand. So I don't know. It just kind of ruins the whole thing for me.
Oh, totally agree. The other interesting pre-auth discussion was for my knee replacement. It was computer navigated, and I had done some reading on it. And while I will say that it's not crystal clear that the computer navigation provides long-term benefits, it's pretty clear that it's beneficial, especially for a uni. And I had an argument with the person on the phone as the patient saying, how can you not approve this? And it was a standard, well, the literature doesn't support it. I'm like, here's the literature that supports it, but I think I got nowhere.
Right. So it's really interesting because I used to know a little bit about that world. I actually have written some papers on computer navigation back when I was a resident, And it certainly improves the technical aspects of the surgery, the time zero kind of implant positioning, et cetera. But I haven't kept up on literature to know, how much of a long-term clinical improvement it has on things like revision rates, because I think it's probably what an insurance company is more concerned about.
Yeah, I think you're exactly right. Um, I do have a case I'd love to get your thoughts on.
Yeah, absolutely. Can I ask you one quick question before we move on from Dupuytren disease? What's your post-op protocol for somebody who's got, somebody who goes to the operating room for, selective fasciectomy to treat a substantial cord for both the MP and the PIP joints for a couple of fingers? And how do you manage that post-op, and what does that look like? Just I think we've had some discussions about it, but I was thinking about it because I was explaining to our fellow Andrew Strzezuski, who was with me in the OR yesterday, just kind of saying how I approach things. And this is what I've fallen into, and it's worked for me. But what's your take on that?
Yeah, well, maybe this is better than the case I was going to share. So I've evolved for sure. So let's say we're talking about a 35-degree MP contracture and maybe a 60-degree PIP contracture. I'm a fan of zigzag incisions. I do not like a single straight down the middle incision with subsequent Z-plasties. I identify obviously the Dupuytren's proximally with the bundle. I also identify the Dupuytren's distally, wherever that may be, with the bundles, and then I work back and forth to excise, ideally sharply, but scissor dissection as necessary. Um, and then I really work hard not to have to do a volar plate release. And I've found it increasingly uncommon that I have to touch the volar plate. And that includes both a complete excision of the Dupuytren's and a gentle manipulation of the PIP joint. I'll stop there because I didn't answer your question at all. But where does your approach differ from what I've just stated?
Yeah, no, same thing. Pre-op, pre-planned Z incisions, Bruner zigzag incisions. Just I don't like having to think about it too much. Clearly, if we need to, we can rearrange things. But that's my gross understanding is that most orthopedic surgeons create these kind of Z's ahead of time, and then the plastic surgeons are fancy enough to just kind of create a straight line and go for it at the end. I don't want to think that hard, to be honest with you. You don't have to. Um, I'm pretty big on finding the neurovascular bundles before I start to cut out any tissue. Just because I was telling our fellow Andrew, I was like, this disease is a formidable foe. Every time you think you understand it, it humbles you. And I'd rather just know where everything is. And it's interesting. I was one of the things I was thinking about yesterday is that I was trying to dissect out these bundles before removing any tissue. But sometimes you got to remove a little bit of the tissue just to give yourself some room to maneuver. So you've got those central cords that kind of spread and fan out across, just proximal to the palmar digital crease. And I don't like to cut anything out until I see the bundles, but sometimes you got to cut a little bit out at least to see the bundles. And then once you kind of get your depth in your plane and make sure they're not doing any kind of, there's not any spiral funny business, then you can start to be a little bit more aggressive. But for me, the stress and the tension is high until I've seen bundles proximal and distal to where the maximum amount of contracture is.
Totally agree. Totally agree. And it's so helpful for fellows to do some open dupes, given how, less common going to the OR is. And so there's nothing that replaces that experience. I think from a technical standpoint, it's one of those surgeries that technically is really important for education and technique development. So love that we, still go to the OR at least some.
Yeah,
Um,
absolutely. And one question I want to ask you is that I don't know if I'm describing this properly or how it's actually been described in the literature. You've got some Dupuytren's that are like a kind of the tightly defined central cord or tightly defined spiral cord, ADM cord, et cetera. Sometimes you just kind of have this nodular deposition of Dupuytren tissue that, for me at least, sits kind of between the palmar digital crease and the PIP crease. And that's the one that I certainly think is not going to be readily treated in my hands, at least with a needle, because it's so broad and so dense that it's not like you can break up a cord and you're going to get rid of that. For me, that goes to the operating room. I don't know how you feel about that. And then, the case that we were doing is super interesting because it had that nodular kind of component over the small finger. And I thought the ring finger was going to do the same thing, but the ring finger actually had a pretty classically defined spiral cord. So do you think, Andrew and I were talking about this, do you think the fingers behave similarly in the same hand? Or do you think it's just going to do whatever it wants to do?
Yeah, it's a great question, and it's actually something we should know the answer to. We being the medical community, I think they can behave quite differently, although certainly there are some patterns that will repeat finger to finger. But yeah, I think they can behave differently. And I have had some success with the needle procedure with that large nodule over the proximal phalanx. But you're right, my expectations are diminished when that nodule is there rather than a clean cord. So I think that's really important. Um, Here's two things I don't do anymore. Number one, I do not pin the PIP joint at all, ever in this procedure. Three things I don't do, of course, three. I don't pin the PIP joint. I don't splint post-operatively, and I'll explain that. And the last thing I'll do is I don't close with nylon alone. I will use nylon as corner stitches and I add chromic or whatever in between. It provides the strength of the nylon and the lack of having to take out a million sutures with the absorbable. So I really like that combination.
Yeah, it's super interesting. So, to comment on your three things, I think the not pinning the joint's a good idea too. Clearly, I think it is, and I try to tell the patients ahead of time, especially the ones with more severe contractures, we're going to get what we're going to get, and it's not going to be perfect. There's always a chance of this coming back. And a lot of times, if they're severe enough where you're thinking about pinning the PIP joint after you've done it, they're probably going to be pretty happy with a pretty substantial partial correction, to be honest with you. Because most of those folks haven't used their hand fully in a long time and really just want to get their hand in their pocket, get their hand in gloves, be able to release things. That's been my experience. I've obviously been doing it much shorter time than you. And then for post-op, actually, I'm curious. I do splint people, but I actually send them to therapy within a day or two after surgery to change out of my plaster splint into a custom therapy splint and encourage motion once the block is worn off if they have a block. And then the third thing is that I still use nylons for these. I hate having to take all of them out. I feel like when I have patients that are going to see their wound sooner because they're going to therapy, the corners really freak them out if you don't get the corners perfect. So you got to get the corners perfect. I've stopped doing a corner stitch as you're taught. I actually just do simples on each side of the corner because I feel like that's a more reproducible thing when you have multiple people that are suturing. And I don't have to keep watching people flail on the corner stitch, and I don't want to kill the corner, to be honest with you. I shifted to that probably 6 or 7 years ago. I probably should use more Chromix. I've worked with surgeons in the past who have used Chromix to kind of work in between areas of simples and mattresses, just to kind of really nicely get the skin together or pucker it exactly how you want it. But haven't used a ton of Chromix. I have switched my carpal tunnel trigger closure thanks to Sam Mogdaderi over in DC. But we could talk about that separately. But yeah, I don't know if you had any thoughts based on the things that I just said.
So I like everything you said. I do use corner stitches with nylon. I agree. The corners got to get right and you got to do them right. And it can be painful sometimes. And then it's sort of maybe one nylon on each limb with, then maybe another stitch or two that's absorbable. My thing with pinning, aside from the vascular concerns, if you've really had a big contraction, then you pin it straight, which you don't worry about the vascularity, assuming technically do your surgery well, if you don't pin it. If you pin it, you have to worry about it. The real reason I don't pin it is I don't know why I would. Because if I've done the complete release, then I've done a complete release and I get the finger straight. If I haven't done a complete release, then I don't know what the pen does for me. And you can say it gives you a stretch. I think that's total BS. And then the reason I do a soft dressing because it lets patients move while the block's working. I think there's probably a little bit of benefit. And then like you, I send them to therapy usually 2 days post-op, and they'll get a night splint for extension. And then during the day, they just work on flexion.
How long do you night splint for?
I ask for 6 weeks, but if patients are doing well, they don't want to do it that long. So I see the patients at 12 days and I encourage them to keep splinting. And I usually see them back at 6 weeks and most have discontinued the splint.
Yeah, so typically we'll do, full-time splinting, but coming out full-time meaning day and night, but coming out to work on active flexion and extension. Starting, within a day or two after surgery, continue that after post-op check one, which is usually at the 10 to 14 day mark, and have them do that for another 2 weeks, like a full month of that, and then just nighttime splinting after that for another 2 weeks.
Yeah, I like it. I like it.
A lot of different ways to
Dupuytrens,
do it.
Yeah, I mean, dupuytrens is the one exception on my scheduling criteria for patients over 40. Now, I don't know how, but I think we've talked about before, plenty of patients over 40 sneak into my clinic. But the one true exception is dupuytrens patients of all ages can come in. And I just think it's so educational, like it's really important for residents and fellows to see.
Right. It pains me now to think that I could not get into your clinic. Now that I've passed that
You're too
age
old.
threshold, I'm
You're
too
too
old.
old. You're not old, but you're too old.
I'm too old for the Go Far Clinic. Well, let's thank our next sponsor, Checkpoint. So our sponsor, Checkpoint, is Checkpoint Surgical, supporting the Wash U Peripheral Nerve course, April 5th and 6th here in St. Louis. Faculty of this course will include myself, Dr. Mitchell Pett, Dr. Wilson, Zachary Ray, and keynote speaker, Dr. Susan McKinnon.
You can register at the link in the podcast description or on nervemaster.com. Hope to see you there. It's going to be awesome. I know there's not many slots left, as I understand it. Maybe you can squeeze a few more people in.
Yeah, it's the whole economy of scarcity thing. So you better sign up. I think we're still in early registration technically. It's gonna be a great program, and we got folks coming back from other institutions that have WashU nerve ties. It's gonna be great. The lectures on Friday. The You get to do anatomy labs with all these people, including Dr. McKinnon on Saturday. I think it's gonna be super fun. And this is a original here. This is an exclusive. Dr. McKinnon has offered on the Sunday morning after the course to do like a fireside chat about cases and give some of her lectures to the people that have come to the course the 2 days before. So that's a new exclusive that's just dropping now. It's going to be publicized eventually. But if you come to the course, you also get to hang out with Dr. McKinnon a little more, which will be super fun.
Wow, that's a lot of learning in 2.5, 2.25 days.
Yeah, it's bonus. You're getting an extra like a half day for free.
Yes, I love it. What do you think? Should we briefly talk about this other case, or should we move on to our
No, let's go to
HBR?
the art. Let's go to the article. I think it's an interesting one, and we can certainly save the case for next time. You know, one of the things that I've noticed is that leadership styles change over time. And we talked about before the people that have been incredibly successful leaders, in the orthopedic world and medicine in general. Generationally, that shifts. And I don't know if somebody who was an amazing leader, 20, 30 years ago would still be the same today. Like, could Michael Jordan play in today's NBA to the same effect, for example? So this was an article out of HBR from the January, February 2024 print issue by Sylvia Ann Hewlett, called The New Rules of Executive Presence. So for those of you that like to download it home, or at least we'll look it up online, let me get the reprint here for you. That is R2401L. But I enjoyed reading this, Chuck. What were your thoughts in terms of, I don't know if you want to introduce the article or give some high level thoughts.
Yeah, so this is super interesting because I've been lazy post-pandemic with my attire. We've talked about that. I use any excuse to wear whatever into the office and change into scrubs. Um, and that doesn't, those kind of appearance, dress for the role you want, those things haven't changed. And this article, I think, is really, really interesting. So I guess I'll start by saying, let's talk about executive presence. I mean, as orthopedic surgeons, as therapists, especially in a leadership position, as senior residents and fellows, you want to have it. And it is something, as the article says, that you can learn. Certainly, some people are born with this gravitas, which is one of the words they use throughout. Others are not, but it's incredibly important to be an effective leader.
Right, absolutely. I mean, they kind of summarize the three big groups of traits to help people with executive presence, being the gravitas, strong communication skills, and having the quote right appearance. Now that obviously all feels very kind of squishy in terms of what that means, and clearly that can change over time. So I mean, when we talk about the gravitas, one of the things they talk about how when they surveyed people or executives in 2012 versus when they surveyed people in 10 years later in 2022, you know, something that came up was the importance of inclusiveness. Now I know that we've had a lot of diversity, equity, and inclusion, you know, content and lectures brought to us in the last 4 or 5 years, and rightfully so. But they're also acknowledging there's been a bit of a backlash in terms of these programs, how appropriate they are, how effective they are, and truly how inclusive they are in some ways. But I think that the inclusiveness aspect has kind of resonated in terms of how you can be an effective leader and really get the best productivity and get the esprit de corps up in terms of morale.
Yeah, I think it's super important, and it's not. And I don't want to. You correct me if you see it differently. It's not just quote unquote DE and I. It's just making everyone in your organization feel welcome and feel like they have a home. Because then you get the best out of everyone. And yes, that may be people that look different than you and me, and that's fine. But it's about that environment that you can create consciously, where everyone is performing at their highest level. That's sort of the way I think about it, which I assume is similar at least to how you think about it.
Yeah, I think so. I mean, if you really want to think about it purely from a capitalist kind of perspective, I'm totally with Mark Cuban on this one. I mean, you're going to get the best business results if you have a more, inclusive environment and you have more different voices in the room and different perspectives. It's just dollars and cents. Now, moving beyond the capitalist part of it, I think you're going to get a better product of whatever your product is, whether you're making widgets or doing orthopedic surgery or plastic surgery or hand therapy. You're just going to get a better result out of the entire team if you not only get a bunch of different voices in the room, different backgrounds, but then also make them feel like they can be themselves.
Yeah, that's exactly right. So what's interesting is both what's changed from a gravitas standpoint and what hasn't changed. So the top two traits in 2012 and 2022 are confidence and decisiveness. And that is not overconfidence, and that's not a feeling that I'm always right, but it's that projection of confidence and being decisive when it's required.
Right, absolutely. And so for those of you that have been wondering what is gravitas, I actually quickly Googled it just to make sure I can give an accurate description because I didn't want to say something that wasn't appropriate. But according to the Oxford Dictionary, dignity, seriousness, or solemnity of manner. Excuse me. So I think that the confidence and decisiveness matches that, but it is a balance, right? What is a common quote about surgeons? Always confident, sometimes right.
Yeah, never in doubt. Yeah, something like that. That's exactly right. The other things on the list for 2022 are inclusiveness, as you started with, respect for others, vision, which was on the list in 2012 but seems much more important in 2022, and integrity, which dropped a little in its relative priority. But I do think vision and being able to articulate your vision in a way that, again, resonates with the entire organization is super important.
Yeah, I think that's mission critical. I mean, especially as we're coming out of the pandemic now, and during that time, I think there were a lot of people that were, I think loss is not the right word, but that were looking for meaning, and looking to be led and have that vision articulated. And I think that you can have a vision, but if you don't articulate it well, like you stated, nobody's going to notice or be inspired. And I think that, no matter what line of work that we're in, like even like, for example, even if you're not in an academic department, but you've got a hand surgery practice or you've got a hand therapy practice and you're thinking about your team, how do you elocute to them, what it is that you want to do that is beyond kind of the day to day of taking care of X number of patients? What is the bigger vision? Because I think that with that in mind, you can use that as your compass to, um, get through the tougher times, when it does feel like a bit of a slog. And it also takes stock of what you've accomplished. So not only think about what you can do next, but what have you already done?
Yeah, and you're right. And the buy-in that you gain with that shared vision goes a really long way, as you said, when things are not so easy and not so smooth. So I really like that. Um, the second area was communication. And again, I love this part because the top two, both in 2012 and 2022, the number one is superior speaking skills. But the second one has a twist, which is in 2012, it was command of a room, which we can all recognize as important. In 2022, it's command of a room slash Zoom. And it is so important that you can communicate and project over Zoom, and I see it done poorly all the time.
Right, right. And I think that, I think we know everybody knows when it's been done poorly, but can you think of some time when it's been done well? Can you think of people that have truly have command of a virtual meeting room, and can get everybody locked in, getting the most out of them without somebody checking their phone or doing emails or literally anything else?
Well, it's hard, and I don't think you can accomplish all of the goals, meaning people come to Zoom meetings with different agenda. Obviously the person who organized the meeting has one agenda. Chuck Wolfhardt's agenda for certain meetings might be to catch up on email. And that may not be changeable, but it starts with, the visual appearance, the lighting, the kind of the voice and the ability to project over Zoom. But then it gets back to the basic stuff, which is, do you have an agenda? Has it been shared? Are you going to work through your agenda, engage with everyone? That's the other thing that I think in 2022 is so important. There shouldn't be silent members of a Zoom meeting. Occasionally you have a huge meeting and maybe there are, but engaging with everyone, whether it's in person or on Zoom, is so important.
Well, it comes down to the basic meeting principles, right? You don't want a meeting that's too large. I don't know who this is originally attributed to, but I've heard Kevin Bozick say it on a few different occasions. Chair of surgery at UT Austin, and fittingly for you, a joint replacement surgeon. But there's a two pizza rule for a meeting. You shouldn't have a meeting if two pizzas can't feed the entire room. So clearly there are some exceptions to that, but I do think that when you have those larger meetings, you're not going to get the level of engagement that you're looking for. But I love how this article talks a little bit about somebody who proactively manages virtual meetings. So there is CFO at an Icelandic real estate firm that has a few simple rules, and at first she does a brief tech check to make sure there aren't any snafus. For us, I guess that'd be cameras on. Let's see where you are, and you make sure that you're not driving between sites or whatever. Second, she distributes an agenda and relevant pre-reads at least 6 hours in advance. Now, clearly, for surgeons, you may want to do a little bit more than that. For most people, but I mean, in saying, I expect you to have read this in advance to get some of the informational things out of the way and maybe stir up some food for thought. And then she starts meetings by introducing anyone new to the group, taking care to highlight skill sets or experience that somebody might bring to a topic. And then fourth, she solicits participation from everyone in attendance, and specifically calling out people that have been quiet. And then I love this one, which I had not thought about, but asking a colleague to write and quickly distribute a summary of decisions made and next steps, which oftentimes will fall on the person who's typically would fall on the person who's running the meeting and organizing the meeting, and honestly can't take as many good notes because they're running the meeting. And then she rotates that role among different members of the team so that everybody gets a turn. I love that. I mean, I think that's gold right there.
I think that's gold as well. And it also, I don't want to say forces engagement from everyone, but make sure that everyone's engaged because if I, ask, hey Chris, great meeting. Do you mind jotting down a few notes? And I don't know if you do that at the beginning of the meeting or the end of the meeting. I think either way works. Maybe the beginning of the meeting is a little safer. Um, and of course, AI can do that for us as we continue our AI conversation. But I love all of those points. What do you think about, and you can be honest, our department and Regis and I both have really been pushing that it is imperative that we have our cameras on during meetings. What's your take on that? And some people believe that it's, we're pushing too much. What's your take?
I think that I understand the intention entirely. I think that it is but one solution to something that requires probably a multi-pronged approach. I think that forcing people to have their cameras on feels a little bit, paternalistic in a sense. I get it. That's going to get people at least to understand that we're paying attention to you. But forcing people to have their cameras on without actively soliciting engagement seems like a half step. I think that, for example, like for our hand service research meeting, which is a much smaller group, albeit, we have cameras on, but the person who's running the meeting actively solicits engagement from people that are involved. And I think that feels different to me, like just to look at it, like that's a meeting worth having my camera on for, because somebody's actually paying attention to me and wants my input. So I think it comes down to basic human kind of behavior. I mean, we don't mind showing up for people, but if I'm going to show up, I want to be part of something. So I don't know if I directly answered your question. And I also honestly don't want to get in trouble.
No, I think you did. I mean, I don't think I see it as a panacea. I think it's one step in trying to create that engaged environment. And look, with a huge department, it's so hard on many levels, which is why all of these factors for leadership matter. Why don't we, if it's okay, briefly close with appearance? I thought appearance, the conversation on appearance is both interesting and tricky. The takeaway for me is be authentic, but look like a leader.
Right. And I think it gets tricky because you certainly don't want to overly honestly think about other people's appearances. Especially gets tricky when you think of more women as leaders. I'm not here to judge anybody. They can dress how they would like, but there are certainly looks that exude more leadership in the kind of classical traditional sense. I think it's important. I wouldn't put too much stock in it because I think things have shifted. But somebody shows up to an interview in a suit, you're not gonna question anything. But if somebody shows up to an interview in athleisure, then you're gonna say, all right, well maybe that's the new norm, but maybe that's not the position that that's not the look I personally would shoot for if I was looking for a job or a position. And I think they talk a little bit about online presence here, and I think that's probably a discussion for another time. But I do think their appearance extends far beyond the physical and extends into kind of making sure if you're not actively cultivating your online experience, making sure there's not anything crazy on there. Because the first thing most of us are going to do is we're going to Google somebody if we're seriously considering them for a position, and you don't want your first, second, or third page to have anything that would raise an eyebrow.
Totally agree. Agree with all of it. All right. Well, it is the middle of the day, and despite the fact that I'm sitting at home icing and elevating, I do have another meeting. I love this conversation. I love hitting the HBR articles because it's great discussion.
Yeah, absolutely. It's fun, especially, with you being in business school. This is basically like you doing your homework, right? So,
My my
so
homework my homework for tomorrow is managerial economics and microeconomics. And I'm like, oh my God, what am I done?
wow, enjoy that. Enjoy your next meeting and your icing and elevating, and let me know if you need your ice pack refreshed. I'm happy to come over.
All right. Thank you
All
so
right, see you
much.
later. Bye.
Bye.